Good morning. We're going to go ahead and get started. Thank you for attending the Healthcare Services Review Project Committee. Our start time is 8:31. So prior to calling roll, I would like to make clear for the record of this meeting, and it should be reflected in the minutes, that at least a portion of this Healthcare Services Review Project Committee meeting is conducted pursuant to California Government Code Section 54953, in that committee member Chris Zuniga is at the alternate location of 4860 El Dorado Drive, Laverne, California. Committee member Zuniga is participating via Microsoft Teams. In accordance with the Ralph M. Brown Act, each alternate location has been identified in the notice and agenda for this meeting. Annette Rivas, it would now be appropriate for you to conduct roll call, after which I would ask committee member Zuniga to recognize me in order to confirm certain matters for the record.
Supervisor Canepa,
Here.
Supervisor Dean, Interim County Administrator Regalo,
Here.
Ms. Hopkins,
Here.
Ms. Van Stein,
Here.
County Counsel Kiernan,
Here.
Ms. Macedo,
Here.
Mr. Wolfcamp,
Here.
Mr. Diedrich,
Here.
Mr. Castro,
Here.
Mr. Nunez,
Here.
and Mr. Zuniga.
Here.
Okay, thank you. I would now like to request committee member Zuniga respond to the following questions. Mr. Zuniga, can you hear me well?
Yes, I can.
Were you able to hear our proceedings on this end up until now?
Yes.
Do you have a copy of the agenda for this meeting?
Yes.
Have you posted the agenda at the location where you are?
Yes.
Is your location reasonably accessible to the public such that any member of the public could participate in this teleconference from your location if he or she wished to do so?
It is.
Is there any member of the public there with you who would like to participate in the public comment portion of this meeting or otherwise address any agenda item for this meeting?
There is not.
I would now like to ask that any member of the Healthcare Services Review Project Committee speak up at this time if such committee member has not been able to clearly hear committee member Zuniga. Hearing no comment, the record should reflect that all committee members present have indicated they were able to hear committee member Zuniga clearly. I would next request that any committee members speak up at this time if such committee member has any reason to believe, based on voice recognition or otherwise, that those persons representing themselves to be committee member Zuniga are not truly so. Hearing no comment, the record should reflect that no committee member has expressed doubt that committee member Zuniga is the party participating by teleconference with committee members present here. I would now like to advise the committee members that any votes taken during the teleconference portion of this meeting must be taken by roll call. Okay, moving on to the next agenda item, to approve the minutes from the March 22nd, 2024 meeting. Hopefully you've had a chance to review. Do I have a motion to approve?
Move to approve.
A second? Annette, can you please take a roll call vote?
Supervisor Canepa,
Yes.
Interim County Administrator Regalo,
Yes.
Ms. Hopkins,
Yes.
Ms. Van Stein,
Yes.
County Counsel Kiernan,
Yes.
Ms. Macedo,
Yes.
Mr. Wolfcamp,
Yes.
Mr. Diedrich,
Yes.
Mr. Castro,
Yes.
Mr. Nunez,
Yes.
and Mr. Zuniga.
Yes.
Thank you. It passes. So the next action item will be presented by Brandy Hopkins. It's a committee meeting moving to quarterly.
Good morning, everybody.
We discussed at our last meeting the potential to move the monthly meeting format to a quarterly meeting format in order to allow departments to have more time to collaborate in between the meetings and provide feedback and updates to this board and the Board of Supervisors. It was not an action item last month, and so I need to come back to the committee for a potential motion second and vote about moving the meeting from quarterly to monthly. If there's any questions, I'm happy to address them. If there are no questions, do we have a motion?
I move to move the meeting from monthly to quarterly.
I'll second that.
Okay, when you said it, Brandy, you said it backwards.
Did I?
Yeah.
What did I say?
You said what we're doing now.
We're going to move from monthly to quarterly. Thank you, my apologies. Okay, can the motion and the second still stand? Mr. Castro, Mr. Diedrich?
Yes.
Thank you, Supervisor Canepa. Ms. Rivas, do you mind taking the roll call vote, since we need a roll call vote?
Yes, I can. Supervisor Canepa?
Yes.
Interim County Administrator Regallo?
Yes.
Ms. Hopkins?
Yes.
Ms. Van Stein?
Yes.
County Council Kiernan?
Yes.
Ms. Macedo?
Yes.
Mr. Wolfcamp?
Yes.
Mr. Dietrich?
Yes.
Mr. Castro?
Yes.
Mr. Nunez?
Yes.
And Mr. Zuniga?
Yes.
Thank you, everybody.
Okay, moving on to information and discussion items. First, we have to present the 2024 financial results through February for the county clinics. Mr. Chris Zuniga?
Alrighty, good morning, folks. I'll go ahead and share my screen. Okay, we begin the discussion with our billable visit trends. For the month of February 2024, we had 11,600 visits. We can see that our visits have recovered from their dip of late 2023. This is due to recruiting efforts and also to engaging with contracted providers, and that's spearheaded by our Chief Medical Officer, Dr. Dulio. So happy to report that we are above the two previous trend lines for February, and much closer to our budgeted number for the month. We budgeted 11,625, and we ended up at 11,601. So happy to report that. This is our income statement for the month. Our 11,000 visits resulted in 1.7 million in net patient service revenue, right around where we budgeted. The story this month is twofold on the revenue side. One is the supplemental revenue, otherwise known as QIP. We have increased the monthly accrual, so we have a favorable budget variance here of 256. We expect this budget variance to exist through the remainder of the fiscal year. So that, plus the 340B program this month exhibited tremendous revenues. We received a payment from the state associated with their supplemental payment program for 340B. And what this is somewhat of a rebate of the rebate. In other words, the state has taken all of the rebate for our Medi-Cal and Medi-Cal associated patients for the 340B program. And based on FQHC's visits, they are sort of giving a portion back to FQHCs. So it turns out to be $6 a visit, roughly. So we received over $700,000 for this payment, and this is the second time we've received this payment, or the second year that we've received this payment. It was a program that we had to apply for and we got approved for. So happy to report those extra funds. Total operating revenue for the month is 4.8 million against a budgeted 4 million, and so the favorable budget variance is accounted for by those two items. The uptick in QIP plus the SSP program for 340B. On a year-to-date basis, we're at 36.5 million against a budgeted 32.7 million. Favorable variance there is largely due to the year-to-date adjustments or history-to-date adjustments that we had in our January financials associated with the QIP program. Any questions as to revenue, folks? Hearing none, I'll proceed to our expenditures. Expenditures on the whole were in line with expectations. You will note that there are some positive and negative variances with almost every category here. What that has to do with is a semi-annual reconciliation with the hospital that we have on our due to, due from accounts. The hospital supplied us with information for their December 31 balance. So we went ahead and did year-to-date adjustments for all the relevant sort of expense categories for which we were supplied information. So a lot of these sort of monthly variances, like for utilities, for example, came from that sort of adjustment process. So $4 million in total expenditures, just about where we expected. Net income for the month is $853,000. Basically all positive variance. On the year-to-date side, we're running just about where we thought we were in terms of expenditures, but there are some notable sort of variances to budget. We've talked about our benefits. We don't need to rehash that, but our professional fees, this has to do with our contracted providers and some legal fees that we've accrued this year. The dues and subscriptions, that has to do with some software purchases. And I think I've mentioned this over the past few months. Software purchases that we made in 2023 under grant programs. So they were fully covered by grants, but we're amortizing the cost of the software during this fiscal year. So just about all the other categories are in line with expectations. Year-to-date net income is $5 million against a budgeted $500,000. So pretty good favorable variance, again, largely due to our quality incentive pool program. Are there any questions regarding our income statement, folks? Okay. And there's more sort of detail regarding our variances to budget supplied in this slide. But you can feel free to peruse those. But I've covered essentially all of them already. So this is our balance sheet. February 2024, we have just about 20 million in cash. Total assets are 46.3 million, largely due to our other assets, and we have our due to, due from the hospital balance there. Liabilities are 9.8 million, and we have total net assets at $36.5 million. So total assets equal total liabilities plus net assets at 46.3 million. And we still have restricted net assets of 2.7. We were able to recognize a little bit of the 3 million that we had in the previous fiscal period, but we're still working with our grant programs in order to recognize these funds as revenue. Any questions as to our balance sheet, folks? Okay. Cash collected, we have 36 months worth of cash collections. And February, just like visits, January and February have recovered. And we're hoping that March is the same. It ended up pretty strong, so we're looking forward to those figures. 1.7 million for cash collected in the month of February, again, above the previous 2 February trend lines. The bulk of our cash is always Medi-Cal, so better than 90% Medi-Cal. And that's true for many FQHCs in California. Here's our correlation between visits and cash collections. Very highly correlated, and that's what this depiction shows. These are our required HRSA financial metrics. Cumulative cost per unique patient is now sitting at $1,100. That will continue to rise as we progress through the fiscal year. There's a few more fiscal periods left, but this $350, $360 value, we've seen that for a number of months, and you can safely say that's where we are currently operating, $360 per visit. And when you compare that to our PPS rates, you can see there is a tremendous gap. Our highest PPS rate is 312. So, and that's at the highest one. Our lowest is still below $200. So we are actually pursuing an intermittent clinic strategy. Our board has approved the pursuit of this strategy, and we have discussions with HRSA in terms of adjusting our hours to comply with the California intermittent strategy. And HRSA has approved those hours adjustments for our clinics. So instead of having 6 PPS rates at the California or Stockton sites and the French camp sites, we will have essentially 2 PPS rates, one for Stockton and one for French camp, that our clinics will operate under. So more to come on that. The state has not approved it yet, but our sort of notification or application has been submitted to the state. These are our financial results against our capital link targets. We're at 13.7, 13.8% profitability versus operating revenues. The capital link target there is greater than 3% for FQHCs. You can see how we fare against the 2021 medians nationally as well as in California. Days cash on hand are sitting at 155 days. Days in net patient receivables are a healthy 34 days, and our personnel related expense, inclusive of contracted services, are 70% of total revenues. Are there any questions as to any portion of the presentation, folks? Hearing none, that concludes my presentation. Thank you very much.
Thank you, Mr. Zuniga. Next, we have Abe Nunez to present the 2024 financial results through February for the San Joaquin General Hospital.
Okay. So we're going to dive into the hospital's financial results for the month of February. Overall, we had a difficult result from a margin perspective. There were really 2 key drivers for the lower than expected results. On the volume side, we had a very soft inpatient census. Our patient days were the lowest of any month this fiscal year. And on the expense side, we incurred a considerable amount of cost associated with training our new registered nurse hires. So as we go forward, it's going to be critical for us to retain these new nurses, since this is more, I guess we should see this more as an investment cost, since if we're able to retain these nurses, then we'll be able to maintain our contract labor line, below what we've seen historically.
We have 144 new nurses. So if you can imagine training typically on a given day, that's more than our staff. So if you can imagine training costs new nurses about 4 months, you're going to see that continue. And the challenge that we've had in the past, and we're trying to make sure that we pay a special attention to that with a union contract. The challenge that we're having is people are coming to San Joaquin to train, and as soon as they get the experience, they're going to other facilities due to the hourly pay. It's hard for a 23-year-old to look at things like pension and cost of benefits that they don't have at other places. And it's hard to convince them that when they're 65, this will be a good deal. So the real trick here is we have had great luck over the last 4 months in hiring and filling all of our roles. You'll see on the traveler side, the numbers are going down significantly. But if we can't change that 0 to 3 year pay structure, then all this might be a moot point, because if training costs, if we don't see at least a 2 or 3 year commitment, then those training costs are really money down the drain.
So when we combine the lower inpatient business and the added costs associated with training our new nurses, we were short of target by 1.4 million for the month, which brings our year-to-date budget shortfall to 1.8 million. When we look at our financial results from a cash flow or EBITDA perspective, we're short of target by 1.1 million. Year-to-date, when we look at the volumes for the whole house, so looking at our adjusted patient days, which is a combination of our inpatient days plus outpatient equivalent days, we're short by 3.3%. Overall, our outpatient business is trending favorable when we look at our outpatient surgeries, for example. But we have to consider that the yield rate associated with those services due to the lower payer mix is considerably lower when we compare back to our inpatient side. We get favorable rates from our commercial payers, in particular for our trauma program for those inpatients, which improves the overall collections rate when we look at the income statement for the hospital. Another positive is that the acuity level or the CMI connected with our patients, we're seeing that metric more indicative of a level 2 trauma hospital now that we've launched our clinical documentation improvement program. So that's helping lift the revenue line year over year. So overall, year to date, when we look at operating revenues, we are favorable to budget by 1.1% or 3.4 million. When we look at our core services and our net patient revenues from our day-to-day operations, those are lower than where we expect it to be due to the contraction in volume. We are seeing a favorable variance when we look at our supplemental programs, largely due to some one-time true-ups connected with some of these programs associated with prior years. And also, as Chris alluded to, we've been able to increase our revenue accrual for the QIP program as the overall pool of funds for public hospitals has picked up. So that's been a positive for us. On the expense side, we're short of target by 5 million or 1.6% compared to budget. Looking at our overall cost per volume metric normalized for acuity, our cost per CMI adjusted discharge, we're short of target by 1.3%. And the decrease in our discharge is obviously impacting that metric, in the wrong direction. And looking at just salaries and benefits, we're very close to target because of our vacancies. And we would actually be considerably favorable to target if it wasn't for those training costs that we're incurring connected with our new registered nurses. So here's the more condensed version of our income statement. You can see that for the month of February, our revenue budget shortfall was roughly 300,000 because of the lower inpatient census, and our expenses were over budget in aggregate by 1.1 million. We can attribute the training cost really, for that unfavorable variance, which leaves us at a 1.4 million budget shortfall for the month. When we look at the year-to-date performance on the right, you could see that from a net loss perspective, we're short of target by 1.8 million, and EBITDA or financial results from a cash flow viewpoint, we're short by 1.1. So here's the more granular version of our income statement. So this is comparing year-to-date versus budget, and also against prior year. Looking at revenues, we're 3.4 million or 1% better than budget. Year over year, you could see that we are favorable to same time last year by 6%, which considering the contraction in our inpatient business, I think that's a strong result. Going down and looking at our overall expenses compared to budget, we're at 5.2 million over, or 1.6%. We talked about salaries and benefits being, less than 1% over budget. But again, when we normalize for the one-time costs associated, we're hopeful that it's one-time costs associated with training costs. If we're able to retain the nurses, that unfavorable variance would have flipped, right? We'd be favorable to budget. Professional fees are over by 8.2 million. But I would point out that when we look at year over year and look at the professional fees line, we've decreased those costs by 25%. So that's a direct result of filling our vacant registered nurse positions and rationalizing the number of contractors we have there at the hospital. Purchase services, you see a considerable positive variance, and that's due to some delays in implementing some of our projects plans for this year. The 3M computer-assisted coding, that's going to be a big lift within our revenue cycle. That project's been delayed, so that's a large reason why we're so much favorable to target. And here's the balance sheet for the hospital. The one line that does stick out is that negative cash balance, and that's directly connected with the timing of the hospital putting up the intergovernment fund transfers connected with our supplemental programs. Subsequently, we'll get those dollars back plus matching funds in the month of March. So when we fast forward 1 month, we did get a check for 94 million connected with our QIP program. And in April, we got another check for 21 million connected with our GPP. So by the end of the year, our cash balance will be much closer to where we ended last fiscal year. And here's our financial dashboard, which measures key volume, revenue, and expense metrics against budget. I'll focus on the right-hand side, which is our year-to-date variance to budget. You can see our discharges are lower compared to target by almost 6%. We've contracted year over year by, I think it's about 7%. So that's obviously impacting our revenue line. When we look at our ED visits, we're short of budget by 6%. And it makes sense to see those two metrics correlate. If you have less patients come in through the ED, that translates to less admissions into your hospital. So we should see correlation there, which we are. On the revenue side, I do want to talk about our commercial payer mix measurement. So that compares the amount of patients with commercial insurance relative to our total volumes. And you could see that we've seen some contraction there. So these patients are the ones that have Kaiser, Blue Shield, United. Because of the lower inpatient business, we've contracted when we look at that metric. The commercial patients that we treat primarily come in through our trauma program, but those patients really bring a strong margin in that the reimbursements from those payers are considerably higher than government. For example, when you look at the overall hospital's cost to charge ratio, we're running at about 22%, so 22 cents on the dollar. When we compare that to what Medi-Cal reimburses the hospital, we get paid 9 cents for every dollar that we bill out. So there's a considerable deficit there. Fortunately, we're able to make up for most of that through the supplemental program mechanism. But you could see the considerable impact to our bottom line when we see slippage in our payer mix. And then down below, when you look at our FTEs, we're running over target, but that's directly associated with the training hours that we're incurring this year connected with our new nurses. So here's some key volume graphs. When you look at our adult inpatient business, top left, our discharges, you can see the blue line is current year, red budget, green prior year. You can see the blue line has been lower than both target and prior year all year. And you can see the month of February, we're at the lowest point in terms of our discharges. Top right, deliveries been trending positively to target and compared to prior year for the most part. Surgical volumes as well, bottom left, but primarily on the outpatient side, we're seeing strong growth there. And ED visits, bottom right, you can see we're lower, which kind of correlates with the inpatient discharges. And here's our cost per volume indicator, normalized for CMI. Overall, when we look at where we stand year to date, we're at 15,600 per discharge. Last year, we ended at 15,500. We would be considerably better if it wasn't for the fact that our overall volumes have declined year over year. And we pointed out to the lower professional fees, expenses on our income statement year over year. And this kind of highlights that improvement. Overall, you could see that when we look at our contract labor dollars for the whole house, we've improved by 29% year over year, or close to 20 million. So the high point in 2022 was during the pandemic, where hospitals had a difficult time filling those positions with full-time employees, but obviously we're trending in the right direction. In terms of opportunities, we've talked about the difference in revenue between hitting 100% of our equipped quality metrics and 75%. I think the focus has to continue to figure out ways to improve on those measurements. We got some good news from CAPH. They were able to formalize a 25% increase in that supplemental program effective January of this calendar year, and they're aiming for another 25% for calendar year 25. There will be some cost measurements tied to those funds, so it's really going to be critical for us to identify opportunities to eliminate any unfavorable variations within all our expense categories. We landed a 7% increase from the health plan. We're starting to see the higher revenues associated with that. That rate increase was effective January of this calendar year. The Cerner revenue cycle uplift project continues. That one's going to be wrapped up here in the next month or two. So identifying opportunities to eliminate manual work so that the teams can focus on the high ROI accounts and collecting every single cent that we're entitled to based on our payer agreements. On the cost side, continued focus on traveler and nurse reduction. We've done a good job this year, but obviously with the onboarding of our new nurses, we have to continue to see that number come down, right? And retain our new nurses so that we don't get to the same predicament of having to go outside the organization to fill those gaps in our staffing. Anything else?
Yeah, three things I want to add, really important. And again, this weekend was a good example. This weekend we had 46 nurse call-ins. 46 nurse call-ins out of 110 nurses. There's no ramifications for it. We're in the middle of a physician union contract where our physicians are paid upwards of the 70th percentile. And there's no movement to a productivity system that pays doctors.
Mr. Castro,
Yeah.
please don't discuss this topic. It's covered under the
Oh, I'm
MMBA
sorry.
right now.
I'm
Thank
sorry.
you.
Okay. And we need the ability to flex. So when our census is low, we have no ability to flex our staff. So you can't run a hospital with your hands tied behind your back and your legs shackled. So these are all the things that when we started the MSA, the whole conversation was we need to run the hospital more like we run a hospital. And I'm not complaining. I'm just saying these are the things. I know things take time and things takes extra time in the county. But these are abnormalities in what we do. And I hate sitting here in front of all of you, giving you negative financial results. But I've tried and tried and tried to make some changes that we just haven't been able to accomplish at this point. And these things are critical because we had an exec meeting and Supervisor Patty was very clear that we will not see the hospital run into negative, and if we are, we'll go in a different direction. That's what he said yesterday in the MEC, and I think it was appropriate. So I'm not whining, I'm not complaining, I'm saying that we can do much better, but we have to be able to operate like a regular hospital.
And we talk about variable and fixed cost. At the end of the day, we're all variable, right? I mean, if our volumes dip, we have to kind of figure out ways to rationalize our cost structure. That's why having the ability to flex is critical for us.
Thank you.
Yeah, that's all I got. Thank you.
Okay, that moves us on to public comment. Annette, are there any public comments?
There's no public comment.
Thank you. And then moving on to any committee members who would like to share any comments. Seeing none? Thank you. There are no closed session items scheduled for today, and our next meeting is scheduled for May 15th. Are we going to continue that with the new quarterly that was voted on today?
We'll keep May 15th, since
Okay.
that's what we noticed on our agenda, and then we'll move to quarterly.
Thank you. So May 15th is our next scheduled meeting. And with that, we will adjourn at 9:08. Thank you.